Today is still interim as we finalise the data set. And here's some photos from data collection in Sri Lanka. I'm not going to go through these next couple of slides in detail, but just showing you some of our primary outcomes for the study. And this is just showing you a sort of a flow chart of who was included and who wasn't. But again, I won't spend a lot of time on that. So just to give you a bit of a feel for the facilities that were participating and for the women that participated in the study. So due to our selection criteria of more than 2,000 births and ability to conduct caesarean section, most of our facilities were secondary or tertiary facilities, with the majority being tertiary care facilities. And the majority were facilities in the public sector. And this is showing in the year before we started the study, the annual number of births, and you can see we had quite a large number of, a couple of facilities with very large numbers of births, so around 15 to 18,000, and then sort of most facilities were clustering around the sort of 2,000 to 4,000 births annually. This shows you the number of data points that we have per country, so the number of women for whom we collected their birth data. Some very small Pacific countries like the Solomons and Timor-Leste, they only had one facility that was eligible to participate, and so they have a relatively small number of births. Whereas countries like, you can see Sri Lanka, Nepal and Bangladesh had many more facilities and much larger number of births. The majority of women, so about 80% of women, were in age 20 to 35, but you can see the proportion with very young or older populations varies by country, with Bangladesh, PNG and the Solomons having more younger women. This also shows you the number of previous births, so approximately 42% overall were having their first birth. But again, this varies from country to country, with more women in Nepal and Thailand having their first birth. This slide is quite important if you think about previous caesarean. So this is looking at the proportion of women who'd had at least one baby, who'd had a previous caesarean section. And overall, 68% had had a previous caesarean section, and with again the numbers reflecting different practices in care across the region. So for instance, in Bangladesh, just under 68% hadn't had a previous caesarean. Whereas in Bangladesh, 55% of women hadn't, and 45% of women had. And looking at, this is mode of delivery. So if you look at the purple line, this is unassisted vaginal deliveries. So overall, 54% of women had an unassisted vaginal delivery. As you can see in Indonesia, only 24% of women had an unassisted vaginal delivery. But this is, in Indonesia, it's particularly around the way the health system is organised, in that women having vaginal births tend to do it in small local health centres, and so they weren't included in this study. So in this study, we're seeing mainly the women that are going to larger hospitals for caesarean section. And just looking at the number of antenatal stillbirths, intrapartum stillbirths and early neonatal deaths across the region, and you can see again it varies quite widely, with Sri Lanka having fairly low rates of antepartum and intrapartum and early neonatal deaths compared to Pacific countries such as PNG and Solomon Islands. And this is just looking at the preterm birth rate, and this partially picks up the talk that we heard last night about the importance of maternal nutrition in terms of birth weight and preterm birth, and looking at some countries in the region with relatively higher rates. So I'm now just going to talk very, very briefly about the pre-discharge survey. So this is where we asked women about their experience of care, and we had 27,000 women, which is amazing, tell us about how they found care. And if we look at, we tried to randomly sample the women that we invited to the pre-discharge survey, and you can see that between all women in the study and the women who did the agreed to do the pre-discharge survey, the characteristics are very similar. This is looking at, we collected 5,700 provider surveys, and our facility teams were amazing at engaging with providers and getting them to participate. And overall, we had 88% of eligible providers provide feedback on how they view the care that they're providing. About 90% of providers were female, and about 63% of our responders were midwives and nurses. Again, it varies quite widely. This is the proportion of the providers that have been in the profession for more than 10 years, and overall about 45% had been in the profession for more than 10 years. But you can see it varies quite widely. So Nepal have quite a young workforce, as do an inexperienced workforce, as do the Solomons. Sri Lanka has a much more experienced workforce. So what are we hoping to achieve with this? We hope to use this data to work with all of you to identify the strengths and weaknesses, the strengths that we can share amongst all the countries, and to identify the gaps that can be improved. We really want to bring women's experiences of care into quality of care evaluation and improvement. We want to work with government and stakeholders to identify priority areas for action at both facility and national levels, and to promote dialogue with healthcare providers and key stakeholders. And finally, to strengthen maternal and newborn health research capacity. So if you want to know a bit more about the project, we have a website. And I would really like to acknowledge the huge team that have contributed to this, to all our country principal investigators, to Dr. Kapila, Dr. Harendra, Dr. Chandana and Professor Kalaruchi here in Sri Lanka, who have worked with us to make it a success here. So thank you for your time, and I'm really looking forward to Professor Chippawan and Dr. Chandana telling you more about the results for their countries. Thank you.
Many thanks, Professor Fiona. Huge data. Still, I think we just have looked into just a glimpse of it, and we definitely need a lot of analysis and a lot of understanding from that. And apologies, a bit of a housekeeping change had to be done. Apologies, I mean, some of the aspects of the data we couldn't manage to see clearly, but we'll definitely follow through. With this, still we have a couple of other speakers, and I'll request Professor Tipawan Leapsutrakul. Well, this was my assignment to ensure her name is right. So Professor Leapsutrakul is Professor at Faculty of Medicine, Prince of Songkhla University, Thailand. She received her MD and diploma in Thai Board of Obstetrics and Gynecology, and a PhD in epidemiology. She has undertaken international consultancies on healthcare reform and reproductive health, evidence-based medicine, surveillance system on maternal and newborn health, proposal development and data analysis in several countries. She received the Outstanding Royal Golden Jubilee Alumni Awards, the Exemplary Researcher Award of Prince of Songkhla University, and Exemplary Award for Academic Services of the Faculty of Medicine. Currently, Dr. Leapsutrakul is Head of Department of Epidemiology and Director of WHO Collaborating Center for Research and Training on Epidemiology. Dr. Leapsutrakul has more than 180 international publications on maternal health, adolescent health, communicable diseases, NCDs, quality of care, and whatnot. So what we would like to hear from her is the findings of the project of global maternal and newborn health platform from 7 health facilities in Thailand. So over to you, Doctor.
Okay, thank you very much. First of all, I would like to thank the chair and co-chair and the committee of this conference. And also that I cannot say that very thank you for the Berlin Institute and Fiona's and GMP team to give opportunity to Thailand to be one of the 10 countries to join this very wonderful project. So now I would like to share about the implication of GMP findings for policy and practice in Thailand. And you can see from the Fiona presentation that the objective of the GMP is very huge. So I would like to pick up some objectives to show about the preliminary results from Thailand. The first one to describe the labor monitoring using partograph and also measure maternal and newborn outcomes. And identify the cesarean rate by 10 Lobson classifications, and also to assess the woman's perspective on companionship and satisfaction during labor and birth. And I would like to emphasize again that this is only the interim data of the some outcomes of the GMP, that the result may change slightly in the final log dataset that Fiona has mentioned. So first of all, I would like to tell a little bit about the study procedure, and Fiona have already presented that in different countries we implemented maybe in different times because we need to get the ethical approval before we starting data collections. And also the ethical we get approved from the WHO and also for each countries. And you can look at for the Thailand join to this project in July and August, and also that we join on the maternal record reviews and also facility survey, provider surveys, and also the pediatric survey. And we have the 7 facilities. We have 2 from Bangkok, the capital city. We have the 3 from the south, and we have also 2 from the northeast. You can see that the duration of the data collection is different. That vary from 3 months, that in the quite high number of births, and we have maximum 6 months to some facility that have the smaller births, and we also get the complete the sample size calculation based on the proposal. You can see that we have the 7 hospitals, and we join for each medical records provider and facilities, and this number you can see that quite not different across 7 facilities. We have the PI, we have the PI coordinator, and this we have the facility coordinator who monitor the quality of the data collections. So first of all, we look at the facility level data. You can see that we have 7 hospitals, and we can see that for intrapartum care, all 7 hospitals, we have the basic infrastructure and equipments that for essential medication and equipments. We have the clear policy on initiations of breastfeedings and also skin-skin contacts within the first hour. I think that all of you in this room also agree on this one, that is very important for policy for the mother and the newborn health. And also we found not all 7 facilities that we use the ketamine. We know that in the past we used this one, but for the quality medication we use less nowadays. And also delay cord camping is not totally 100%, just only 2 hospitals not have the written policy guideline to the hospital. If we look at the early postnatal care, we can see that we have the 100% on after the woman give birth, at least 24 hours, they need to observe to see whether that they safe. We did not discharge them before 24 hours. And we have the available medications, and also we provide information and counseling before they left of the hospitals. And one hospital, they have not written clearly on the offering paracetamol. They just ask the woman if they request for that pain relief. And to hospital also that we did not give the NSAID to relieve pain. And we have 3 hospitals that used to look at the skin virtually, and also we test the blood from the baby, not use the TCB for the screening on hyperbilirubinemia. Now, I think that I don't want to emphasize too much number, but I would like to tell you that this is very important because Fiona already presented that we have the findings, the difference across countries. So now when we return back to Thailand, we have the 7 hospitals. If you look at the characteristics of the mothers, you can see that across 7 hospitals, we have the different nature of the mother. You can see that on average, we have the mother who is lower than 20, around 5%. And we also quite almost 1/4 of the mother who have the age beyond 35. And also that if you look at across 7, you see that almost double we find in the hospital in the northeast of Thailand, and also we found that the younger age is lower in the south of Thailand. When we look at the elderly that more than 35 years, you can see the same that we have across or disparity hospital in Bangkok, capital city, and also the hospital in the northeast of Thailand. And also we still have the single moms in the Thailand. You can see that the majority is also in Bangkok and in the south. If we look at the previous birth number, you can see that nowadays I think that all of us have recognized that the total fertility rate of the global is now declining. In Thailand, 10 years before we have beyond 2, but now we have lower than 2. It's just only 1.2 or 1.5. And you can see that we have the first mother who comes to give birth almost half. And we have more than 2, just only 5% on average. And we still have the number on the south. So it's good that south of Thailand, we still have the more pregnancy women, right? So we can get more than 2 births is around 10 in the south of Thailand. And also we look at the previous cesarean section is average. If you have more than 2 sections, we can find around 7%, and also in the south of Thailand because we have number of the births, so we have opportunity to get cesarean section. And also that if you look at the number of antenatal care visits, you can see that very small number that the women not come to the antenatal care, and we found in the hospital in Bangkok that we have the not non-Thai citizen, they come to Bangkok to work. So we have the quite of the number of this group of the women who have no antenatal care and come to giving birth at the hospitals. And we have seen that the majority of the women have antenatal care more than 8 times more than the recommended by the WHO. And when you look at the pregnancy complication, you can see like UNICEF also talk, UNFPA emphasize on anemia in mother. We can see that we found around 22% of the women still have the anemia during pregnancy. And now diabetes come to more than 10%. And also the pregnancy-induced hypertension also have quite common in Thailand. And you can see that the less location is mean that they have the different pregnancy complication, have the difference across 7 hospitals. So we need to see what is the magnitude of the complication, and then we need to solve and see the root cause of this problem and solve one by one of the hospital. It depends on the context. And if we look at the preterm birth that Fiona have mentioned, we also say that we still have the pocket of the preterm that allow more than 10%. But we are still lucky that we still have term is more than 80%. So now I would like to emphasize related to interpartum care. I would like to list some issues to talk today related to the progress of labor monitoring. You can see that on average we have around 70% of the patient in our 7 hospitals get the labor monitoring. You can see that is the history, right? This one is the visual simplified labor curve. This one is labor care guides, and this one the freshman curve. I don't know whether that Shanana will talk whether that what's the Sri Lanka use about the labor curve. You can see that for the majority of the hospital, if they use the labor curve, they have the variation. Most of the hospital in Thailand, we use this curve. This is a freshman that is progress is need to be higher than the alert line of the visual simplified graph. Now we come to the mode of deliveries. We still have the vaginal birth allow 40%, and we have the vacuum or the forceps extractions allowed 4%, and we have the cesarean section is 56%. And we also have the planned cesarean section, I don't know here, and then we also have the emergency cesarean section. You can see that the maximum is for each mode of delivery is varied by across 7 hospitals. I think that the balance of the male and female quite similar for all hospitals. And for the low birth weight, we found around 14%, and also we have lucky that low APGAR score is low in Thailand. Now I also would like to emphasize on the cesarean section rate by using this Robson classification. I think that all of you have know about this one, that we use the 6 basic indicators: parities, previous sections, onset of labor, number of birth, gestational age, and fetal line and presentation to classify the classification into 10. If you look on this left side, it means that the cephalics, it means that the fetus have the cephalic presentation for each, and for the first and the second is nulliparous. It means that the women who have experience of giving birth before. The first one is spontaneous labor. The second one, that I underline, the blue line, is induced labor or cesarean section before labor. And the 3 and number 4 is also multiparous, and without scar. On the number 5, Robson number 5 have the scar on the uterine, so it means that have the previous section. And on this side, it means that the not cephalic presentation 6 and 7 is representation. For 8 is multiple pregnancy, this 9 is oblique presentation, and this 10 is preterm. This one is a 10 Robson classifications. And what I would like to emphasize that in Thailand we have the cesarean section around 56%, and you can see that the majority that previous section almost 30%. And if we look at Robson number 1 and 2 is nulliparous, is also 30%. You can see that the high age on each cesarean section rate by each Robson also different across, but still Robson number 5 is also majority of the all 7 hospitals. Now we move to the outcomes. You can see that for the death, right? You see that the total stillbirth rate in Thailand is average around 4.4. In Thailand, the Ministry of Health, Public Health have set up that we should have lower than 5, so we lower than the target threshold of the country. However, we still have some hospitals still higher than the average targets of the Ministry of Public Health, so we need to see and how we can improve this condition. And if we look on the neonatal mortalities, we have set up 3.6, so we still do a lot of work to reduce this one because the average on these 7 hospitals we have slightly over than the threshold. And for the preterm birth, we have around 14% that I already presented. And also when we look at the categories of the preterm, we found that the majority is also that around 32 to 37. Now we come to the mother. I pick up only maternal death, so you see that now during the data collection we did not find any maternal death. And then when we look at the measure of sick, I pick up the postpartum hemorrhage. I think that all of you also agree with me that postpartum hemorrhage is the quite measure of sick complication makes the mother death and even near miss. So you can see that we have the average on postpartum hemorrhage around 4% across 7 hospitals, and we have the variations, but the maximum is double in the Bangkok. And when we have the postpartum hemorrhage, the majority we use oxytocin to treat. And also that apart from that, we also use the ergomectins, and also we use thiazidinic acid to reduce the blood loss. And also we have the surgery around 10% that need to do the invasive procedure. Now we turn from the medical record to the woman perspective. So I pick up the companionship. This one we get from the answer for the woman, and based on this is ATMP, we use the tablet and the woman record their feeling by themselves, that confidentially. So it means that they open mind and they usually answer without any forcement or scare on the provider because they did not know any result or the answer. So we find that when we ask about the companionship, we found that around 70% of the women say that yes, they prefer the companionship during the labor. Not 100%, I don't know, it's quite surprised, right? Just only 7% say that, yeah, they want someone that not health provider to be with them, to support them. And among this group, we found that around 70% of the women receive what they want. If we look at during delivery or during birth, we get lower number. The women just say that only around 60% I want someone, right? And around half they receive what they want on average. And we can see the variation across the 7 hospitals. And for another, apart from companionship in this GMP, we also ask about some feeling related to the physical or verbal mistreatment, whether that you are pinching by the health provider or you just have some provider talk loudly to you. And they also, yes, they also found like that. That is around 5% that provider maybe some pinching or scold to them. And also, because we also have the non-Thai citizen, they may feel some discrimination in some is around 3%. But we found that for the consent on the vaginal examination, when they giving birth or during labor, we almost 100% get this consent. And also all of the women certify on the care that they receive from the hospital, almost 100%. And they have the small that not answer. Now we come to the discussion. What we found nowadays for the preliminary data. If you look on this one, I emphasize on the cesarean section rate by Lobson because Thailand also consider on this issue. And this one show you that I use the data of national data and we do the trend and we predict. You can see that this one we use the national data, so they have much more the involvement of the hospital, not only the high number or the tertiary hospital. So if we do nothing here, you can see the trend of cesarean section rate. If we do nothing, we have the higher cesarean section rate, and we need to do some intervention to reduce, right? But it's not yet, we cannot see much. However, when we see to look at the cesarean section rate, we have this one is from our GMP. This one from the previous publication that also used some of the hospital, also our 7 hospital participate in this GMP. You can see what we found. We found that previously data we have around 45 to 55%, but now we get 56. So not quite huge increase because we have the data on 2016 and now almost 10 years. It's not like some the trend that previously. So we see that even we don't have any quite clear intervention, but all provider and all women also realize that cesarean section rate not only benefit, but also if unnecessary, they will have some risk or some complication to mother and the baby. And if you look at the Lobson, the number 5 also high. You can see that the same proportion in this group of the Lobson and the number of nulliparous and also that induced. You can see that number 2 and number 4 is mean that induced labor and Caesar before labor. So we don't want that much number, right? So we need to do more on this one because it's increased when compared to the previous study. So if you look at about the companionship, we can see that is quite good compared to the previous study in Africa, India and Oman. And also that we found a systematic review that collect from the 51 study. But on this one, most is come from high income countries, show that women want companionship during labor and birth. And they also happy to get that one. I think that in our data also show the same that all of them that also want companionship and they get on that one and they satisfy on what we get. So this is my last slide that what the importance of the data that we can do on the implication for policy and practice in Thailand. I pick up the conclusion that we found 2/3 part of the progress of labor. Even all labor have monitor, they have the paper and they do record every cases, but not labor care guides not is used in Thailand. So we need to dissemination more about the labor care guide, what is important, how we can save the mother, how we can reduce the near miss of the mother and get the improved appropriate cesarean section rate. And also that we need to look at the nulliparous to get the primary section because we don't have the VBAC policy. So it means that the first section we need to get the second one. So we need to emphasize on this one. And we found increased rate of induced and cesarean before labor, and we have the rate increase compared to the previous study in Thailand. So we need in-depth discussion on the benefits of the Lobson classification for both women and provider. And we need more intervention how we can do together to make more safe of the mother and the baby. And also that allow 2/3 of the and also half of the women desire and get the companionship. And we get very good satisfaction. So we need more to understanding resource settings. And yesterday, last night, we also say about the resource limited or resource constraint that how we can do better health with these limitations. And also we need to look at the factor influencing the satisfaction because it's not only mid-treatments or not only infrastructure, but they have both clinical and non-clinical that also influence to the satisfaction of the woman. I would like to finish my presentation by the acknowledgement to all of the one who makes this project accomplish. Like last week, we also finished for all data settings. So I think that this is very important. So apart from the visual Burnett Institute, and also the team of the global platform for maternal and newborn health, and also that we need to thank Ministry of Public Health of Thailand and Royal Thai College of OBGYN who support and see this important that let Thailand join this project. And also we need to think about the ethical committee to review and leave approve that we can do this project. And also all facility coordinators and also data collector as well as the women and provider who held this successful project. Thank you very much.
Thank you very much, big point for making that very interesting presentation with most of the data that you have gathered. I'm sure there will be more discussion at the time of panel discussion. To present the GMP data from Sri Lanka, and we have two presenters. Firstly, it will be Professor Chandra Jayasundara, who is a professor in the Department of Obstetrics and Gynecology at the Faculty of Medicine, University of Colombo. And the next, it will be Dr. Kapila Jayarathna, who really doesn't need any introduction to this audience. He's the current president of the College of Community Physicians of Sri Lanka, and he's actually at the moment a senior lecturer in community medicine at the Faculty of Medicine, University of Colombo as well. Over to both of you to make the presentation for Sri Lanka.
Thank you, Professor Chairpersons, and all the distinguished guests in this summit. So what we thought with Dr. Kapila, we had a discussion a few days back, though I thought that we would discuss how we conducted this project in Sri Lanka. I would discuss that, and Dr. Kapila would go on to discuss the results, the key findings that we came up in the study. So I would just want to go through the background. So we know that good interpartum and early postnatal care is crucial for improving maternal, fetal and newborn survival and well-being. And in Sri Lanka, we don't have country-specific standards, and we can always try to incorporate international or WHO standards, but they don't represent our local needs. So there's an uncertainty that exists whether are we aligning with the WHO, or are our standards up to the world standards, or do we need to improve, or are we okay with the standards that we have? So that was the main objective. And with that in mind, we wanted to establish and sustain a local network of health facilities providing childbirth services to measure and improve the quality of interpartum and postnatal care in the future. So that was our objectives. I'm not going to go into this slide. The primary objectives and the secondary objectives were presented. I think Fiona talked about secondary objectives. Primary objectives, actually, it was basically to evaluate the quality of interpartum care and postnatal care provided in women and newborns in participating health facilities, and particularly in accordance with the key WHO interpartum and early postnatal care recommendations, whether it's implemented, and to get the women's experience of quality care that they have. So this was a novel thing to the Sri Lankan setup, actually. And to measure the frequency of maternal, perinatal and neonatal morbidity and mortality related data in relation to the interpartum and immediate postnatal period. And in the future would be to monitor the trends of these indicators, how will it improve with our interventions. So secondary objectives I won't go. So it was, the study was conducted in 15 health facilities and across the country. So normally, I think Fiona was talking that we take the central city, the capital and 2 other provinces. Actually, we wanted to include in Sri Lanka, there was so much variety in practice in all over the country, so we included central province, North Central province as well, an additional one, with a high delivery rate, which also would more globalize our results to whole Sri Lankan setup. So that's why we had to go to another center as well. So individual provider and facility level data were collected through medical records, and we sampled women in the pre-discharge survey, which I will talk about it a little bit more in detail. So this is the WHO and the Burnett Institute. The recommendations was what I told, like one major city and the other 2 cities, but we included more. So when we started, we had a problem. When we started the project, there was a trade union action with a lot of government turnovers going on, and so we were lacking. We were lagging in starting our project. Funding came, but the funding was not able to be utilized because the university system was malfunctioning at that moment. So we were struggling, and from there, somehow we managed, after the trade union actions were over. After that, we had a problem with data collectors, because by that time we recruited medical students, but by that time the medical students were not there because it was delayed. So we had to go with the newly recruited medical students and not pre-intern medical students. Actually, they did a quite good job. I assure you, they were not the students that we recruited have not worked in Sri Lankan hospitals, but they had to learn the system, the Sri Lankan system, and then start collecting data. So it was a huge task. So I can remember me, Kapila and Harendra, we had to go around Sri Lanka to hospitals and try to get things sorted out. Sometimes they were not willing to go to the wards, and they were frightened because of the system differences. So we had to go all over the country. So we wanted to represent the whole country. So these centers go far and wide apart. Anyway, things started, and so this, you can see the months that the study data collection period is dependent on the delivery rates that we had. But we, by the time that this was decided, and by the time we started the study period, then only we realized, my God, our delivery rates have been dropping like hell. And then the sample size collection was another issue. So you can imagine things have changed so fast during these 2, 3, 4 years in Sri Lanka. So I don't think any other country would have experienced this. I don't know, but yeah, we had huge challenge. But we managed to start data collection in these provinces, western, southern, eastern, and northwestern provinces. What is that? Okay, so just to say about the study surveys that we did, we had a pre-discharge survey, which was a novel method to Sri Lanka. We used tablets and we translated the languages to Sri Lanka, Sinhalese as well as Tamil. So that is the first time in Sri Lanka that I think this type of data collection happened. And then we did the provider survey and the facility survey. This was done through facility surveys. The provider survey was done through interviewing the healthcare personnel, and the facility survey was done through capturing the records, the medical records. So we tried to be as thorough as possible. So we collected the data in accordance with the WHO Burnett Institute data collection protocols that were updated to us very frequently, every weekly or monthly instead. And data were collected electronically through with tablets that were provided to the data collectors. And we had regular meetings with the country coordinators and the WHO and the Burnett team for smooth running. So I would like to, so first me and Harendra, we attended this meeting in Thailand, and we were briefed about the whole project and how to conduct it. It was very intensive 3-4 days that we spent there from 8 o'clock to 4 to 5 maybe. I think I went to Thailand, but I didn't see anything outside Thailand. Stuck. And this is when we initiated it in Sri Lanka. So we first initiated, we selected our candidates to collect data, and then we briefed them. We had a collaborative meeting with the Burnett Institute as well. They supported us. I can remember Fiona coming to Sri Lanka itself to initiate the study initiation with our data collectors. She went all around the country. So it was a huge effort on Burnett Institute side as well. I have to acknowledge that. So from here onwards, so we started collecting data, and finally we have finished collecting data happily. And so Dr. Kapil will carry on from here to present our data set, which is the most valuable one. Thank you.
Thank you, Chandana. Actually, I think this may be after 10 to 15 years that we have nationally representative local data. So we studied 14,680 total births. So you see the educational level, our women are 91% more than the secondary school level. Primaries constituted 43% and P1 or P2 51%. You see the teenage is 3.6 and fairly significant level of advanced maternal age 16%. And you see our anemia level in pregnancy, which is a challenge, it's 31%. Diabetes, I saw in Thailand also the very much similar prevalence, nearly 14%. Hypertensive disorders 7.7% and placenta previa 0.4%. So the initiation of labor induced 33%, a fairly high percent. I think this has been the scenario in Sri Lanka over the past few years. And partograph, labor monitoring using a partograph 94%, and cadre of health professionals attending birth, you see midwife nearly 90%, a nurse more or less universal, and doctor non-specialized 88%, and the consultant specialist 4%. Period of gestation at delivery, majority more than 37, nearly 89%. And the Robson classification, you see the women with the previous cesarean section, 64% had no scarred uterus, then 1 and 2, 26% and 9.2% respectively. So cesarean section rate 46%. When I saw the Thailand rate, I was a little happy. And you see the Robson classification relevant domains. Here we see group number 2, 27%, group number 4, 10%, and 5, 33%, again 10, group 11%. So when you look at this, you must be familiar with this. As a community medicine person, my knowledge is limited on the classification system, group 2, 4, 5, and 10. With regard to routine fundal pressure applied during vaginal birth, 38%. We have still this practice, and episiotomy, 87%. So, I mean, many people were asking when we presented this interim analysis data from the other countries as well. But you see the third and fourth degree perineal tears, 0.9%. Hysterectomy rate of 0.9%. Routine antibiotic prophylaxis at birth, all types of birth, 47%. Normal vaginal birth, 15%. Assisted vaginal birth, 36%. Cesarean section, 81%. And this is important maternal ICU admission for more than 24 hours, 0.6%. And we had postpartum hemorrhage all times, 2.4%. If I can remember, Thailand, it was 3.204. PPH after vaginal birth, 2.6%. After cesarean section, 2.2%. And similar to Thailand, we also had no maternal death. Newborn characteristics. Total newborns studied 14,865. You see unassisted vaginal births 52%. This is very much similar to what I presented earlier. Cesarean section 46%. And preterm births. Earlier, what we had was the global survey which we did in 2010, 7.9%, but you see now it has gone up to 11.3%. All births, 11.6%. Then preterm birth categories wise, majority late preterm, 32 to 37, it constitutes 86%. So birth weight, median 2,890. Low birth weight rate, I think this is consistent over the years. As far as I can remember, it was 17%, but we had the national statistics. We had now it is 18%. Less than 1,500, 1.6%, and majority between 1,500 grams and 2,500 grams, 16%. Suspected or confirmed IUGR, nearly 6%. Breastfeeding initiated within 1 hour, 94%. Vitamin K, more or less universal. Neonatal hyperbilirubinemia screening, 79%. Apgar score less than 7 at 5 minutes, 0.3%. And NICU admission rate of for more than 24 hours, 6.5%. So our perinatal mortality rate is very good. Total stillbirth rate of 3.7, and intrapartum stillbirth rate, we were little worried, and when we compared with Thailand, it's more or less similar. and early neonatal mortality rate of 3.7 per 1,000 live births. So basically what is important in this data at national level, so we can see the advanced maternal age of 16%, the profile of pregnancy complications, anemia, then 31%, diabetes 13%, and fairly significant proportion of hypertensive disorders, and there is a low non-cesarean delivery models we apply, and rise in cesarean section and high induction rate. Now, I mean, with this study, now we have the quality and robust data based on Robson classification, so we can better utilize them, and continuing practice of episiotomy, the preterm birth, because our infant mortality rate, the causes wise, is 29% due to preterm birth, and stagnant low birth rate, where we have to work on, and the good positive finding of low stillbirth rate and low neonatal mortality rate. So I want to thank our research team, especially pre-intern medical officers who worked tirelessly over the last few months. Actually, as Fiona mentioned, we finished this data collection last week. So these are sort of interim data. And our team from Professor Atula Kaluarachi, Professor Chandana Jayasundara, Dr. Harendra Dasanayaka, and we as a team, we worked very hard over the last 5 to 6 months, and I have to appreciate the guidance and the support given by Bernard teams and the WHO headquarters. So when we had problems, they all supported, and thank you for selecting Sri Lanka for this study, because it's very timely, and we can utilize this data in a rational way. And I have to appreciate obstetric and neonatal teams in all these facilities, 15 facilities. When we visited these facilities, all of them were very cooperative and supported us, especially obstetricians and neonatologists, and hospital authorities, directors, they supported us very well. And I have to acknowledge the support given by our Dean, Professor Vajira Disanayaka, and our supportive staff, Mrs. Achala, and pre-intern medical officer coordinated this project at national level, Chamat, and especially Ministry of Health and Family Health Bureau. So all the communications were sent through Ministry of Health and Family Health Bureau. I think Dr. Chandima Siritunga is here. I have to acknowledge Dr. Chitramali Disilla, who supported wholeheartedly to this project, and the, again, GMP team. Thank you very much.
Thank you very much, Kapila and Chandana, for those presentations. Next, we have a panel discussion. I would like to invite Dr. Harendra Dasanayaka, who is the President of the Pediatric Society of Sri Lanka and former National Manager, Maternal Morbidity and Mortality Surveillance at the Family Health Bureau, to come forward, and he will moderate the session. And as the panelists, I would like to invite Professor Nishani Lucas, who is a professor in the Department of Pediatrics at the Faculty of Medicine, University of Colombo. Dr. Sanat Akmimana, who is the President of the Sri Lanka College of Obstetricians and Gynecologists at present. And Dr. Abner Daniel, who is currently working as Health and Nutrition Manager at University of Sri Lanka Country Office. And of course, Dr. Chandima Siritunga, who is a consultant community physician and the director at the Family Health Bureau, Ministry of Health. So over to the panel, and hand over the mic to Dr. Harendra to moderate the session.
So, very good morning to you all, and we'll move to the, because of the time constraints, we'll move to the panel discussion straightforward. And I think we heard a lot about the GMP survey and the activities and the preliminary findings of the study. So there are many things that gives concern, and then there are some findings which are compatible with what we know. But as a whole, I think it's a great opportunity for us to gather a lot of important data. The problems that we have is the lack of data, whether even though the data is available, it's not collected and properly analyzed. So now we have done that. And going on to the discussion now, we have a team of panelists here, and I would like to forward the question to all of you all. Looking at the available data that was displayed, though it's preliminary data, I would like to get your opinion and your views on the different areas, especially regarding the findings, whether you all agree with it or not, and then what are the way forwards in going with the available data. So I would first invite, looking at the obstetric data and the childbirth and the antenatal and intrapartum care. I would like to first get the opinion of the president of the SLCOG, Dr. Sanath Akmeeman.
Thank you, I would like to thank Dr. Kapil Jayaratta for inviting the SLCOG to this kind of discussion. I think there's no doubt about data is very collected, and it's a very good platform to open discussion on certain things. So therefore, as we discuss, we can see what are the things we can improve on. And there are some areas like episiotomy rate and cesarean section rate needs special attention, but globally, is it all right if I continue to speak? Talking about cesarean section rate globally, when I look at data, say in UK, in United Kingdom, with all levels of care, high income country, their cesarean section in 2024 is 42%. And Australia in 2022, 39%. And United States of America is about 33% in 2023. I don't have the data for 2024. So by looking at the Sri Lankan data, 46.5% is this. So what is the major concern? Why you are worried about this cesarean section? It's a major surgery, and it has its own complications. Okay, but as I saw from this data, the collected data, the placenta previa rate was about 0.4%. So that's a big one. So on the other hand, what are the reasons for rising cesarean sections currently? One is, I must tell you that about 90% of the deliveries taking place in government hospitals, and about 10% deliveries taking in the private sector. And the private sector, you know that cesarean section is very much high. I think more than 95% is used by cesarean section, private sector. So that also contributes to these figures. And other thing is, there are, as you said, the elderly mothers percentages represented about 68.5. And because of this present concept, the mothers, the women in this country, the first pregnancy to become pregnant is quite late because of the financial things and as well as academic things. They study more. They go to universities, they study, and by the time they become pregnant, they are really old. Other thing is, because of that, there are medical complications. As I saw, about 21% of them having either hypertension or diabetes in this study. So these problems, and then the obesity. It's a new problem. There are many pregnant mothers, they are very obese. In addition, the IVF pregnancies. IVF pregnancies, there are no proper regulation, and there are multiple pregnancies are happening in the country because of no regulation. There are multiple embryos are transfers, and the special care units in and around Colombo full with these extreme premature delivery babies, and even difficult to admit a properly indicated patient to a PPU because of that. So this has led to the rise of this figure. As when I'm retired now, but before my retirement I was at Colombo Teaching Hospital. My C-section rate was around 30 to 38% at that time. So this common figure 48.5 come from that also. Say 10% see 245 deliveries in 2023, 10% comes about 2,400 deliveries. Out of that, 90% cesarean section very high is come. This need to address that also. On the other hand, I must tell you that in peripheral hospital, as a consultant, I have worked in peripheral hospital with limited facilities, very limited facilities, as well as very limited committed staff. I mean, the senior house officers, they are just doing a job. They do just a job, and not like a postgraduate training, where there's a career pathway for them to develop for the essential nothing. So that's why we mentioned that to create a middle grade cadre is very important to retain the experienced people in this area. That is one thing. And the other thing is legal protection. As a first contact person, if some adverse effect happen to a mother, say maternal death or newborn death, who's going to protect me? I'm the first contact, and I have faced it myself. And there's no system in the Ministry of Health to protect the obstetrician or the other side. So because of that, we have very low threshold to resort to cesarean section. As well as if you can take the newborn neonatal care, right? The places I have worked, they didn't have a neonatal ventilator. When we see a meconium, we are little scared. Sometimes I have to transfer the patient from Paro to goal. Paro is to find a ventilator. So in this type of situations, we have a very threshold, low level threshold in performing cesarean section. So all these contribute. So it's multifactorial. You just can't haphazardly say, look, the Gamba Yogi and tell you, look, your cesarean ratio is high, come down. You can't do that. Yeah. So you have to have a common platform in a broad way to address this.
Yeah, I think we all agree on that aspect, and I would like to forward the question now to Dr. Nishani regarding the preterm births. Now it says the preterm, according to the study, the rate is 10.8, and the extreme preterms are 4.8. So what is your opinion, idea on the findings? And
I think first of all, I'm really happy to see a number for the extreme preterm births, because this is the first time I'm seeing a number for a national figure, although it's not done. There are a couple of centers involved. What we have seen so far are single center studies where we have described what the rates are. So first and foremost, I'm really happy to see prematurity was classified. I've been asking for this for a long time, so really happy about that. And also I really don't have any other previous national data to compare this 4.8% with to say whether it has gone up or come down. But from what we are seeing, and from what Dr. Akmimana said, we are facing lots of problems with multiple preterm pregnancies coming after IVF. And sometimes there's a lot of pressure because they've been subfertile for a while. Sometimes it's 22, 23, most of the time below the level of viability, or sometimes it's 495 grams. Then if the baby is breathing, yes, it is 5 grams below the level of viability, and we may not fall in trouble for not doing anything, but we feel bad as well. It's very difficult for the team who's handling it. Sometimes even it's 490, 485, it goes like that. So even for 200 grams, we are called. So again, the problem is sometimes the gestation is not accurate, so we go. Again, there is a problem with the legal protection, as you mentioned, for us as well, because we don't have any withdrawal of care plans or limitation of treatment plans, and therefore sometimes, so again, people are scared. These extreme preterm babies, when they come, they are there for a very long duration, 3 months, 4 months, and we still have the same number of ICU beds, maybe a little bit more. But with this high rise of extreme preterm babies, without proper laws and proper awareness in the sort of the clientele as well, if once we intubate a patient and put onto a ventilator, even if we are seeing grade 4 hemorrhages or very poor prognosis, removing the child from the ventilator, sometimes even though the parents are also, in our culture, they also feel bad as a parent to say take it off the ventilator. But so there are a lot of issues like that, but we can't take it off because it will be called murder without any legal protection. So I think, been telling this earlier as well, so I think it's a good forum to say that it is really time to have some laws and to say when we can actually withdraw care, when we can sort of limit the treatment, and it goes for the same. I think you did not, I did not see the data on the breakdown of the neonatal deaths. So again, prematurity and congenital abnormalities, lethal congenital abnormalities. Abortions are not legalized in our country. This again is another huge problem because babies are born alive, patients are transferred, because I work in Colombo, one of the tertiary care hospitals, patients are transferred from far and wide because there's a lot of pressure on the VOGs at that end. To send, then lethal cardiac anomalies, a lot of things come. And then again, there is pressure to put these babies in the ICU. We try not to, but sometimes if you do put, they are there until they die. So they are not going to get better, and the bed won't be there for somebody. Sometimes just, need few hours of ventilation to save the life. So there are lots of issues like that, which need, I think, attention. And looking at extreme preterms, I'm very happy because they are very high maintenance, very costly. And we faced a lot of problems in the past. We are surviving on the line right now, but from parenteral nutrition to surfactant. Yeah.
Right, thank you. So now regarding the use of partogram, I think we have fairly good usage, and now we are using the modified version of the partogram as the national partogram. Now, what is the way forward? This is for Dr. Siritunga. What is the way forward in introducing the labor care guide that is the WHO accepted?
Actually, now it was piloted, and after the discussions, after the revisions, now the revised guide is also going to be piloted, and it will be implemented as per the discussion. And I would say that for the previous school speakers, comments regarding the cesarean section and all these IVF and all these neonatal care and all these things, as you know, now we have recently introduced this. We have guidelines on assisted reproductive technology. The guidelines are introduced, and also the new interventions such as neonatal retrieval care system and various kind of starting training for the emergency care after the neonates and obstetrics and all these introduced at the moment. So. And I think we need to have a facility survey, and at the moment we are going to have this national survey on emergency obstetric and neonatal care assessment survey, that CMOC survey, is going on this year. So after this survey, we will be able to find all the gaps and what are the improvements to be made. So I think that is going to be a major achievement in our this thing. So these are the things basically I have to say. And at the moment we are doing this pain, we are introducing the pain management and other companions and all these, even though it's in minor state. The Ministry of Health is in the process of these things. Thank you.
Yeah, I think, thank you for the encounter, and I think looking at the interviewing the women, we had quite a good encounter regarding pain relief and their perception and the provider perception, the receiving pain relief around 85-90%, that sort of. So now we have to go into detail and do further analysis. And the question is now for Dr. Abner. Now we have seen advanced maternal age at a higher level, and then pregnancy complications like anemia, diabetes, hypertension, and you have witnessed all the other data that were presented. So in this context, what is your opinion, and how would you be able to support Sri Lanka on this?
Thank you so much for this opportunity, and also congratulations to the team that has been working for this this data collection. So I think a few reflections I'd like to share after listening to the presentation. So one is the need to transform the way we look at the performance of our health systems. The shift that I feel is required is to move from looking at survival to look at survival and well-being. And why this shift is important is to then reflect on the high cesarean section rates. So for example, what is it that we are missing when the vaginal delivery does not happen? And it is important to reflect also on some of the recent studies that are coming up around, for example, the seeding and the feeding of microbiota, right? The impacts, the long-term impacts that these lack of exposure to the microorganisms can have on the growth and development of young children. We also have partnered with the Perinatal Society and the Family Health Bureau to undertake a similar kind of an analysis of the low birth weight data and its link to cesarean sections. And the analysis is ongoing, but it also indicates that the early cesarean sections have direct impact on low birth weight prevalences. On one side, we argue that our low birth weight prevalence in Sri Lanka is stagnant, it's not moving. But here I see a kind of a low-hanging fruit, where if we have adequate measures to ensure timely cesarean section and prevent early cesarean sections, then there's an immediate impact on low birth weight as well. So there are many aspects that we need to look at, but our objective should not be limited to survival only, but also to look at the larger implications of how the outcomes of our health system delivery is. And I feel that the data on quality is so important, because access, I think to a large extent we have addressed the issue, but the gap in quality remains. And as we saw in the first presentation, the definition of quality, it's not only limited to clinical competence, but it moves much beyond. And finally, to also reflect that we should not, in Sri Lanka, we should not wait for studies to tell us this, like there has to be a culture of data monitoring and accountability. Right? So we, in our routine work, we should get the data that we think is required to improve our programs. I think I'm sure we are moving gradually in that direction. And finally, the culture of learning through operations research. It could be something that we could do on a more ongoing basis to learn what is happening, say in terms of intrapartum care, early postnatal care, and use the information and data to adjust our programs. So I look forward to working closely with the Ministry of Health, Family Health Bureau, the professional colleges, and as UNICEF, we stand committed to support the government in this journey to address the quality challenges that the country faces.
Thank you, Dr. Abner. So I think now this is the interim analysis. We have to go for further analysis, and we will learn more lessons once we do the final analysis. So looking at the data and the quality of data, I think we work so hard on improving the quality of data. And as you said, we are talking about evidence-based medicine, practicing evidence-based medicine. So I think we have a good chance of doing that, looking at this data and then thinking of generating data and doing further analysis with your own data and using them for practice. So with that, I think we have come to the end of this session. And I thank all the participants and the speakers and the panel for the valuable discussions and the data presented, and I hope everybody gathered something from this, and we'll look forward to improving our health system with the learned lessons. Thank you so much.
Thank you for the panelists, and that concludes a truly enriching and thought-provoking session. So we extend our thanks to all 4 distinguished speakers for their insightful presentations, and to our eminent panel for steering a dynamic and meaningful discussion. Your contribution have shed invaluable light on the critical intersection of evidence, policy and practice in maternal and newborn health, offering not only knowledge but also direction for both action within Sri Lanka and across the globe. So this time we would like to show our heartfelt gratitude to our distinguished speakers by presenting them with tokens of appreciation for their contribution to the Global Public Health Summit 2025. So these tokens symbolize our collective thanks for their dedication to this cause and for taking the time to inspire us with their knowledge and experience. So to award the tokens, I cordially invite the session chair, Dr. Farooq Qureshi, representative of WHO, to the center stage. First, I would like to invite Dr. Fiona Bruinsma, Senior Research Fellow from Global Women's and Newborn Health Working Group at the Brunette Institute, to receive her token of appreciation. Next, we invite Professor Tipawan Liabashchukwu, Head of the Department of Epidemiology and Director of WHO Collaborating Center for Research and Training on Epidemiology at Prince Songkla University, Thailand. Next, I cordially invite Dr. Kodituwakku, the President of the College of the Community Physicians of Sri Lanka and Senior Lecturer in the Community Medicine Department at the Faculty of Medicine, Colombo. And finally, I invite Dr. G.M. Chandana Jayasundara, Consultant Obstetrician and Gynecologist from the Decisive Hospital for Women, to receive his token of appreciation. Next, to present the token to the panel members, may I cordially invite the Professor of Obstetrics and Gynecology, Professor Abdullah Kadwaraj. Now I would like to invite the panelists, Dr. Harindra Dasanayake, the President of the Perinatal Society of Sri Lanka, to stage to accept his token of appreciation. A round of applause, ladies and gentlemen, please. Next, I cordially invite Dr. Sanat Takmimna, consultant obstetrician and gynecologist. Now, may I cordially call upon the stage Professor Nishani Lucas, Senior Lecturer from the Faculty of Medicine, Colombo. And next, I invite Dr. Adna Daniel, the Health and Nutrition Manager at UNICEF Sri Lanka Country Office. And finally, may I call upon stage Dr. Chandima Siratunga, the Director of Maternal and Child Health at Family Health Bureau, Ministry of Health. And now to present the tokens to the session chairs of Plenary 1, may I cordially invite the Conference Chair of the Global Public Health Summit 2025 and the President of the College of the Committee Physicians of Sri Lanka, Dr. Kapila Jayarathne. Dr. Kapila Jayarathne, to Dr. Farah Qureshi, the WHO representative of Sri Lanka, and next to Professor Abdullah Kalwaraji, Professor in Obstetrics and Gynecology. So with that, ladies and gentlemen, we conclude the opening plenary session. And as we proceed through the day, let us continue to reflect on the knowledge shared and the commitments we can make to deliver high quality care to the public. So as we now take a short break, we invite you to